In this webinar, we shall learn about antibiotics for treating sepsis in neonates. The learning objectives would be why rational use of antibiotics, initial choice of antibiotics, when to upgrade the antibiotics, how long to give antibiotics, and what are the best practices one should learn. Excessive use of antibiotics, we all know that lead to high risk of antibiotic resistance and higher risk of invasive candidiasis, necrotizing enterocolitis and death. Once we decide to start antibiotics, let us now learn how to choose the initial antibiotics of choice. The initial empiric choice of antibiotic should preferably cover both gram positive and gram negative bacteria. In India, the bacterial and profile of sensitivity of early onset and late onset are similar, and hence no distinction is required in antibiotic choice between these two profiles. The plan would be for community acquired sepsis, a combination of ampicillin plus an aminoglycoside could be the empiric choice. If evidence of staphylococcus infection is present, such as skin lesions, cloxacillin can replace ampicillin. For hospital acquired sepsis, a combination of cloxacillin or ampicillin and an aminoglycoside could be the empiric choice. The choice between cloxacillin and ampicillin would depend on the prevailing flora of the unit. However, it is crucial to avoid third generation cephalosporins, carbapenems and vancomycin as first choice of antibiotics. The next question is when one should upgrade the antibiotics to the next line. Consider upgrading in case of worsening or absence of improvement after 48 hours of therapy. An early escalation may be considered if the newborn becomes extremely sick or deteriorates rapidly. Second line antibiotics should be based on the blood culture report if available and based on the sensitivity pattern of the unit. Even though initiation and escalation may be done empirically, do not hesitate to downgrade to a narrower spectrum antibiotic once the culture report is available. This de-escalation should be done even if the baby shows clinical response. Always use only one antibiotic to which the organism is sensitive. In this slide, we will learn how long the antibiotic should be given. If meningitis is diagnosed, give for 21 days. If blood culture is positive, give for 10 to 14 days, and if culture is negative and the newborn presented with severe clinical signs such as shock, sclerema and DIC, consider duration of 7 to 10 days. On the other hand, if the culture is negative and the newborn had less severe clinical signs, consider stopping antibiotics by 5 to 7 days. In asymptomatic neonates with only risk factors and culture is negative, antibiotics should be stopped immediately. In all cases, keep in consideration the status of clinical signs. In a baby in whom the clinical signs were less severe and the newborn shows rapid improvement, you can stop antibiotics within 12 to 24 hours starting antibiotics. It is vital to understand to decrease the duration of antibiotics. To facilitate this process, certain key steps are essential. First step is to collect the blood culture reports on time. This can be done by calling the lab or starting a system of online reporting or SMS based services. Once you get a report, trust your lab. Even the best microbiology services have only up to 35% culture positivity rate. If reported negative, believe the report and stop antibiotics. Getting a faster culture report is another way by using BACTEC or a similar automated blood culture systems. This may help. Do not give antibiotics in certain scenarios. These conditions are certain non-infectious conditions like asphyxia, meconium aspiration and prematurity and low birth weight. Certain procedures like exchange transfusion, central line insertions, endotracheal intubation and phototherapy should not start antibiotic. Remember few best practices to rationalize use of antibiotics. First, have a written antibiotic policy in the unit and strictly follow it. This policy should state when to give a drug, which drug to be given, how much and how long to be given. The policy should also have the provision to track the organism profile of the unit. Second, do not give prophylactic antibiotics and do not give parenteral antibiotics for simple superficial skin infections. Establish the correct diagnosis with the help of clinical and microbiological support. Do not forget to send blood culture for starting antibiotics and prescribe the right dose using a standard drug formulary. The take home messages are: have a written antibiotic policy for your unit, send blood culture before starting antibiotics, based on the culture and clinical signs, stop antibiotics at the earliest, document the indication, review date and proposed duration of antibiotics, follow the right dose and frequency and follow the instructions for drug administration. Thank you.